Good evening, ladies and gentlemen, colleagues and friends. Thank you for joining me once again for an evening session of SPG webinar. Tonight's topic is on the management of the missing dentition. It's a new treatment planning module that we're doing, so hopefully you'll enjoy this session. Now, joining with me, as always, are my colleagues and friends, starting from my left, Dr. Agnes.
Hello. Hi, everyone.
Dr. Zoe Potres.
Hi, everyone.
And Dr. Johnson Chou.
Hi, everyone.
And tonight, as always, we'll be bringing to you a live interactive session of approximately 2 hours long on this particular topic. So feel free to send in your questions either via that chat link, or you can even submit a case. If you just scroll down to the bottom of the current screen that you're seeing right on the bottom, there's a button for submit for you to include, say, some clinical photos or x-ray of some sort. And of course, please do make sure that you have permission from your patient to send in such cases, so that I can then bring it to the panel and for the rest of the viewers for a discussion. A couple of disclaimers before we get started. This event is sponsored by Noble Biocare, but no panelists here takes any financial endorsements for their products or services, and of course the content of this presentation are of our personal opinion. So please exercise discretion of how you interpret and use this information when treating your patients. Like I said earlier, our evening is sponsored by our long-term sponsor, Noble Biocare. It's a company that I've been working very closely with for over a decade long now, always been supporting me in these continued education events. We're running a course, which is the Noble Biocare mentorship program, which is an implant course. This is going to be in 2024. It's going to be the fourth year running, spanning over 4 different modules of a year long, concentrating starting from the very beginning in treatment planning, then the surgical component, the restorative, and finally a more comprehensive full arch approach. So take you through from even if you don't have any implant experience. I think this is quite a good course for you to look into. You can find out more about the course if you want to just take a picture, a screenshot of that QR code, and that'll bring you directly to the website. The website content is still being updated as we speak. It is still in because they're doing up a new website at the moment. So not all the information that I checked today are absolutely correct, but it's pretty close to the final version. Now, for the ones that's joining us for the first time, Sydney Prosthodontic Group, we are a multidisciplinary specialist practice, sharing our rooms with a team of endodontists and periodontists. But within the prosthodontic group ourselves, there's 5 of us, and together between my colleagues and I, we are able to provide you and your patients a full range of restorative and surgical services, including implant surgeries and so forth. Our mission at Sydney Prosthodontic Group has always been a long-term relationship building, whether it's with your patients or whether it's with yourself. So if there's anything that we can help out with, whether it's your patients or any other questions that you may have regarding patient management practice, any other issues, again, like I said, between me and my colleagues, I think we are capable to help out in some capacity. So please don't feel shy to get in contact with us and reach out for any assistance, particularly with bigger and complex cases. And certainly I've had the pleasure of working with mentors early on in my early years, getting a lot of good advice that way. If you have missed out or joining us again for the first times, don't worry about the previous webinar that you have missed out previously. So if you go to our website, spg.com.au, and then you click onto I think it's for dentists, and then resources page, you would find there's a list of all the previously recorded webinars for your ease of viewing. So coming to the topic of discussion for this evening, as I was saying, this is a treatment planning a module, but with particular emphasis on a replacement of the missing dentition. As we know that there are many different causes for the missing dentition, but irrespective of what the cause may be, of course, ultimately we are looking for that long-term, predictable, functional, and healthy outcome. But before, I think we're just going to jump straight away into the missing dentition component. I just want to take a step back because looking at what is treatment planning generally speaking, because treatment planning means different things for different people. We're all being taught at the undergrad level, right? Treatment planning is always about assessing the patient. We've got to examine extra-orally and intra-orally. We've got to communicate to our patient what the findings are, different what are different options, your diagnosis, etc., and at the end, coming up with certain options, each with their pros and cons for your patient. So really, it's a risk assessment to some degree from your patient's point of view. But I don't think there was a lot of emphasis on treatment planning for ourselves, the clinician. What about risk assessment for us? Is there any risk for us, the clinician, to treat? Is the type of patient that you are is suitable for us to manage? I don't think there was a huge component in that at least when I was going through my undergrad training. So I think I just wanted to explore that component just a little bit, because with some of these cases with missing dentition, not just one missing tooth, sometimes there are multiple missing teeth, and sometimes there are multifactorial reasons why the patient had all those missing teeth in the first place. So they're sometimes not that straightforward to tackle from both a clinical and sometimes from a social sort of point of view. And that's why I wanted to have a chat about that. So let me share with you one particular case of mine from very, very early on in my career as a specialist. This is a fairly young male patient who presented. He found us from the internet, but otherwise wanting to replace his pre-existing veneers. As you can see, he's got 10 units of porcelain veneers from the 1.5 to the 25. He's not very happy with it because of the aesthetics. He felt that they were too opacious. There's not enough layers of colors. There's not enough translucency. The shape is not ideal in some aspects. So when I first saw him, I was reasonably confident and comfortable at taking on this case because when I assessed his aesthetics, yes, I can see the concerns that he had. I agree with what he was saying. Furthermore, we can see that he doesn't. His oral hygiene is not the best, but it's workable. It's reasonable. He does not have a significant amount of dental parafunction. His occlusion is also reasonable. Canine guidance on both sides. You don't see a lot of attrition. So, from a technical standpoint, I thought this wasn't too difficult. It's a cosmetic exercise. As long as we follow the right sequencing from start to finish, we should get a predictable end outcome. And so we went. We started off with again, this case is more than 10 years old now, but this is the digital smile design back then, and then we had a wax up. So we took off the existing veneers, put in the provisionals, in which of course he's more happier with the shape. Interestingly, he selected his own ceramist, someone who I never worked with before, but I knew of his excellent reputation within the dental industry, so I felt comfortable using his chosen ceramist. And as you can see, the ceramic work is excellent. In all parameters, whether it's the marginal fit, whether it's the anatomy, the emergence, or the contacts, etc. So I was quite pleased that of the caliber of ceramics I was working with. But unfortunately, that's sort of the end of where the pretty pictures would go, because the long story short is that I did about 5 or 6 different try-ins. Now each try-in takes about 3 hours, because you got to put local anesthetic, you got to take off the provisionals, you got to put it in, and then he wanted to have some changes regarding the shade, and so these veneers have to go back to the ceramist, and you got to put on new provisionals. So, but I was in my early days. I thought this was just a tug of war. I wouldn't say enjoying the process, but I was very passionate. I was very eager. I want to help the patient. I want to do the best I can. And to me, it felt like a challenge. I got this. I can, maybe I can win this patient over that maybe someone else couldn't. So there was a sense of pride during that process. And at the end, whether it's the number 5 or number 6 try-in, it was right before Christmas. And he said in the chair, he was looking in the mirror, goes, "That's it. This is it." We were literally high-fiving each other. And then I cemented everything in using clear resin cement. And then I set him up with a mirror again, thinking that we're going to get a glowing review today. What then came out of his mouth, it was far from what I expected. I still remember to this day. It was, "It's wrong, it's wrong, it's all wrong." And that feeling, how that your heart just sank to your pelvic floor, that sort of feeling, that's how far it went. But once that's in, what more can you do? There's not much. So then subsequently there was a lot of discussion about what can we do. Well, not much in terms of the color. And then he really turned from actually a very nice, respectable, reasonable person going through that phase. The tone of his emails, phone calls, subsequent reviews, body language, everything have changed. It's as if it was a different person. And that's what really shocked me. How did otherwise I thought it was a very good professional relationship turn from that to is 180? I mean, I didn't do anything wrong. In hindsight, I would do, clinically speaking, I don't think I would have changed much, if anything at all, because I followed every single T, every single bit to a T. And then I started to do a lot of self-reflection. Now, at the end, was we decided to give the patient a refund because it was so uncomfortable. I guess to the point there was threats of legal issues and all that. We didn't want to, or I personally didn't want to go through that. So it was just a full refund out of the pocket, and that was a very expensive lesson learned. So it was probably my second year out as a specialist. So then I did a lot of self-reflection, which is, where did I go wrong, and what would I do differently now knowing what I know? And from what I learned, the first thing that we picked up on is the fact that I don't think that he had a reasonable amount of trust in me when we first entered into this professional relationship. He came in choosing his own ceramist. On one hand, I thought at the time, oh yeah, he's quite particular, maybe had a high level of expectation. That's what we usually say in the dental industry. But in this case, it is not normal to choose your own ceramist. Now, I have had situations where, oh, my neighbor is a ceramist, or my good friend's a ceramist, and therefore I want to use them. I think that's reasonable. But here, he has no relationship or other awareness. So he, in other words, this persona wanted an excessive amount of control because he does not trust the judgment that I was going to make at the end of the day. He wants to make that decision. Another issue that we had was only later on, as I started reading our communication log between our receptionist and him, is that he used a variety of different names. So when he first called up, it was a different name. In the new patient form, it's a different name. And on the credit card, it's even a different name. So again, that exhibits signs of mistrust. He doesn't trust us to even tell us his real name at the beginning. So So I think that's one aspect that I learned, that that patients that we treat has to have a reasonable amount of trust as they enter into relation. We all need to gain the trust of our patients. Yes, we have to work for it. Your trust, we all know that trust is not given, it's earned, but there has to be a reasonable limit before we start. And if there's very little trust demonstrated from the word get-go, that to me could be a red flag. And then another type of patients that I have had troubles even recently is a group of patients who's demonstrating sort of like an extreme form of self-centeredness or egocentric type of personalities, because when they are so self-centered, they cannot see that their problem could be coming from them. They would think that everything and any problem that their denticians have ever suffered is from bad dentists, horrible dentists, butchers, dentists that treated them without long vision, without foresight. They just keep on taking out my teeth without explaining why. It's because of lack of fluoride, bad genes, bad parents, whatever it is that they would say. There's very little ownership of their own history or currency of issues. For example, if a patient is suffering from a quite a significant form of parafunction, and they have no acceptance of responsibility that they have to play a part in its management, and if they play no part in that, doesn't matter what we put in their mouth, things may just wear or crack or break. And then you have a very difficult time trying to explain to them, well, why the titanium or the zirconia that you put in your mouth may not have lasted as long as it should. So do be careful about that. Another group of patients, I think, sometimes to be aware of is the ones that may not be as reasonable or rational to treat. This is a solicitor, a mid-aged male patient who recently have had an extraction, which is going through reasonably uneventful healing. So the work's done outside, and this is when I first saw him. That's on presentation. It's a healing socket. And he wanted to have an implant done. He just basically said, yes, I was referred here because I heard you do implants. Can you, I would like to have it done as soon as possible. When can you get it done? And I said, well, first we do have to carry out some sort of assessment. Ideally, I would like to take a 3D bone scan, a Cobham CT of some sort, so we can have a look at the bone volume. But given the extraction is quite recent, I'm not sure whether taking a scan right now at this very stage would be that meaningful. But at some stage, we do need some sort of radiography to assess the bone volume, the nerve position, etc., etc. And he just said, no, I don't believe in X-rays. I think X-rays can give me cancer. That spiel. And he's one of those patients that says X-ray will give me cancers. And so then I try to reason with him, the importance of it. We can take a very small micro field, which is using the endodontic mode, very low dose radiation, using this radiation chart, telling him that it's quite safe in the realm of radiation, and how in the importance it is, and this is our standard of care. And it's not just for this fake's sake for us, but also for your safety too, because there's a very large nerve there, and we don't want to damage it. I say you're a solicitor. I think you should know that by now. That the medical legal, right, assessment and consent and etc. is important. But despite all of that discussion, the answer is a hard no. So, to the point that he wouldn't even allow me to take a PA. So. I could only unfortunately say to him, I'm sorry, then I'm just not good enough to tackle on cases like this, unfortunately. Yeah. Another sort of small group of patients, sometimes their behavior is just very, very different to the norm. Now, again, I fully appreciate everyone is different, and we're all individuals, and we're here to celebrate these differences. But there are sometimes the differences could be a little bit too much. And you just have to watch out for that, because an extreme form of personality may mean that they interpret information just simply differently to the 90% of the patient you treat. So if they're going to interpret information differently and behave differently, then they may interpret the rational information that you give them. When something goes wrong, you try to explain things in a reasonable, logical manner, they may also interpret that differently. So you have to then make a judgment for yourself whether that degree of difference or behavior that you're able to handle if something goes wrong. So take this situation here, for example. This is a new patient that was referred in. I think it was for an occlusal discomfort, and she arrived earlier, and she requested a couple of pieces of paper and a pen from the receptionist, and she sat down and started writing. It was 45 minutes later. She's completed 4 pages, and she said, "Yeah, I just want to, give Dr. Ben a very detailed history of my history. I appreciate history. It really helps me a lot to understand, what the patient, what's being done, what's tried, what worked, what didn't work. But that is not normal. As in, I shouldn't say normal, but that's not common. You do not see that every day. So when a patient exhibits that type of persona, well, you have to, again, as a clinician, make a judgment on, are you good enough to manage that type of character? That's all. I personally now know my limitations, and it's not very high. So I'm just a dentist. There are many sort of personas I am not equipped to deal with. So I worked out where my limitation is, and therefore, whenever I see certain type of behaviors and characters, I'll say, well, I just don't feel confident that I'm the right person for the job. But I have plenty of mentors, tutors who is a lot more experienced than I am. They have another extra 10-20 years of experience on the top of me. They have so much more experience than I have. I think they're definitely going to be the better person or clinician to look after you and to manage your issues. And yeah, I sometimes do decide to walk away, because I do not feel I am the best person for that particular situation. So so once I think we've covered quite a few of their intra-oral and extra-oral issues, and now we have some idea of their general behavior, right? Then you sort of have to ask yourself some hard questions. One is that if the patient decides to complain, or you're starting having some sort of a complication or failure, we now have to have into some sort of more uncomfortable, sometimes sort of discussions. Do you think that you're able to handle this person, and what sort of protection do you have within the system that you work with in your setting? So, for example, when I have did the veneer case, subsequent to that, in our practice policy, we've introduced a mid-treatment termination policy, which is just to say that if during treatment, if either party feels that we're not getting anywhere, it is not getting the result that we want, and we want to depart amicably, well, let's work out a financial arrangement of some sort, so that we're not leaving you hang dry. We're going to leave you in a stable condition, but we're both going to be able to walk away. And number 2, we introduced a cementation consent, which is just to state that now that things are tried in, if we are using definitive cement or bonding agent, we're going to insert that prosthesis. Once it's done, we cannot change things very much. So subsequent to introducing some of that, and also I think maybe being a little bit more sort of cautious of the type of patients that we treat, we are sort of reducing these issues a lot more. So yeah, that's I guess my sort of first message, or the first concept here is, what is treatment planning? Well, in addition to objectively having an assessment of the patient, but it's also to somewhat subjectively work out when not to provide the excellent dental treatment or the modality we have, but perhaps not to the patient that's within our management realm of manageability. Couple of questions, all regarding to veneers, which isn't really today's topic, but we'll just quickly cover them. They look like Emax veneers. Yes, the new veneers for that particular case was made out of Emax. Another question is, you mentioned feldspathic porcelain or Emax, or using porcelain as a generic word. Okay, well, porcelain is a generic word, but then under the word porcelain, you could have feldspathic porcelain, or you can have lithium disilicate, which is Emax. So there are two slightly different classifications of ceramics. Feldspathic porcelain is it's primarily made out of feldspar with little crystals, a percentage of crystals, anything I think up to less than 20%, I think, could be classified under feldspathic porcelain, whereas lithium disilicate is like, was it 50% roughly of lithium disilicate crystals. So it's slightly two different systems. And finally, the question is, what cement do you use for veneers? For either feldspathic or Emax veneers, you would have to use a resin cement, and ideally a light cured resin cement as opposed to dew cured, because light cured usually it's a little bit more color stable when compared to a dew cured resin cement. So let's thank you very much for those questions. Ladies and gentlemen, keep the questions coming, and again, I will direct these to our panel as we go along. So now that we sort of worked out which patient that we intending to treat, and let's assume we have one of these sort of cases walking in with a very challenging and a complicated situation with missing teeth, significant loss of the occlusal vertical dimension, lack of missing posterior and anterior dentition, significant bruxism, very unfavorable occlusal scheme. Radiologically, there's failing teeth, abscesses, left, right, and center, lots of issues. So where do we start? Because it can be quite a complex situation. Now, before we just going to again jump into treatment planning of these cases, I think again let's just take a little step back, look at how can we visualize perhaps at the end using a concept that Dr. Agnes is going to share with us.
Thank you, Ben. So when we think about how to visualize an outcome, to then devise an approach, it's very important that you think of it almost like a holiday, right? And you can imagine that you know the destination, but still you need to have enough knowledge of the place that you're about to visit in order to even visualize or map out your itinerary. But along the way is actually to do with the experience that is together as both the clinician and your patient. The reason why I use the word experience is because for all of us, we have always been able to think back to the days of dental school. When you first go to the sim clinic and you try to design a restoration and think about the tooth preparation. Many of us, if you're newly developing your skill, you won't be able to completely appreciate three-dimensionally what you're about to do. And your educator will try to see whether you have the understanding with diagram, etc. Moving on to building that experience as you come face to face with your patient who walk in with a certain clinical presentation. Depending on your skill level, you will be able to then start to visualize things. And we all go in there with a certain bias, depending on what kind of clinical challenges perhaps we've just encountered. But we begin to eyeball things, so to say. But that comes from the level of experience that the clinician has, whether you can see, oh, there's occlusal discrepancy, there is occlusal canting, derangement, as you observe the patient's gait as they talk to you, the sense of oral comfort, as you build your experience, you'll be able to visualize more along with the knowledge that is within you as a clinician. But I like to use the word here, experience also, is because when you are treatment planning, it is also the patient experience. So this is coming from a completely different perspective. We know from studies actually have said that there is much better quality of life outcome as well as patient satisfaction outcome when patients themselves are involved with the treatment planning process. And that begins with your first interview and the process of forming your diagnosis, being able to explain things, of course, along the way of going through treatment options and devising a plan, so forth. It is that patient journey. It is not sometimes only about the final destination. We can all have a trip to France. However, we may not enjoy it all so equally, depending on that itinerary and that experience. And in the end of the day, we may all also be after different things. So this visualization of outcome is so critical, whether you are a developing clinician, experienced clinician, or the way you are able to utilize this visualization instead of being within yourself to come up with a plan to try and stage everything to hold that stability from a clinical perspective, in terms of utilizing and exploring that visualization with your patient as a communication tool. Because what all those stories that Ben had actually shared with us today, it seems to be there is some kind of there are qualities in patient that perhaps you just can't seem to get across. But to be able to have a tool where you could cross-check whether we are on the actual same platform along the way is so important. And when there are red flags along the way that, hang on a minute, we actually, no matter how we try, we're just not in the same synchrony or on the same platform, then you much rather to know that earlier on before there's any further commitment. So the very first type of visualization of outcome and a great clinical learning tool for clinicians is an intra-oral mock-up. So intra-oral mock-up is something that it is a chairside tool, often used with composite resin, where it is very easy to use. We're all very familiar with, and you can just puddle and shape over the patient's teeth without the use of any etch or bond. What it does is, as we adapt this composite resin onto the actual teeth, we are coming from a point of an emergence that is very possible. They are from the existing range of the teeth position. And the final outcome is very representable of what a near enough outcome can bring. So in this particular case here, you see that, of course, it's not to say we don't discuss the other options such as orthodontic management, etc. But it gives the patient an understanding that without, for example, a multidisciplinary approach such as orthodontics, with the limitation of only doing additive and restorative approach, there's of course an improvement, but to what extent? And how that actually feels against those lips, and how does that actually feel for that immediate sense of comfort and speech, or the interrelationship to the lower incisors. For me, I feel that this is quite a relatively quick approach. It gives quite an immediate effect, and you could gauge your patient's response. Once you establish any particular reference, you can also easily take a model or putty guide so that you can further develop these concepts that you have validated chairside with the patient visually and physically into the laboratory to see if you could further develop from that point. So I would say these clinical chairside mock-up, try not to go beyond a quick 10-15 minutes. It is not supposed to be an exercise that demands too much of your time, but it is something that it's very good for you to practice eyeballing your line angles, or which reference out of all those deranged teeth would you take to sort of begin to redevelop or reorganize that aesthetically, etc., etc. And from a patient perspective, it's a great experience. So from then on, whether or not you have done an intraoral mock-up, the next type of visualization that is a great tool, not just for the clinician and the patient, but now clinicians, we all have to work with other people, such as our friendly laboratory. So diagnostic wax-up is something that I feel very important to be utilized with, whether it is with our ceramist or with interdisciplinary as we involve other disciplines. With diagnostic wax-up, it is sometimes useful to have done sort of a semi-intraoral mock-up to give references now to translate to the laboratory. But other times, it can be utilized with just photograph. And on the photograph here, for example, you can see that this particular patient came in and she has concerns about her front teeth. And there's chipping, there's like little diastema, there's overall some shape and the bulbous of the cervical margin, there's a localized inflammation in certain papilla, a range of different concerns. So to address this, we can actually use the photograph to devise whether she's actually more or less happy with her midline. From her photograph, we can also see whether we could just work out a nice proportion, a pleasing incisal length, and from there we can request the laboratory to come up with a mock-up with using wax on her models. We can then use a putty key to translate this wax up into her mouth to see whether she, again, physically like this appearance or not. And before we continue to hold those records, as clinician, it helps us to visualize the end outcome. Therefore, now we know how much exactly we need to reduce depending on what type of material we would be utilizing, of course, marrying up, the stump shade, etc., which today's webinar is more focusing on the trim planning. But, these information can then feed through, because now, whether it is the ceramist who's trying to help us on the other hand with the materials that they have or we order, whether it is for the patient, they have an understanding now if this is the final outcome, without, with the teeth being where they are, how much teeth are we looking at to prepare, and that kind of what difference does it make? There is that understanding coming from different perspective and different needs as to what is being involved. So nowadays, more to our tools, what if we're not so hands-on, or in our undergraduate training, there is a bigger movement now to be quite away from model work and laboratory work. And that's not to say that you would be compromised in any way. No, but the core understanding is still fundamental for the clinician to be able to equip with this knowledge. But what is really advanced now, whether it is from the undergraduate field and to now this ever-changing industry, is having a digital mock-up. And its development with the AI has just come such a long way. So with digital experiences, it is amazing. It is an amazing tool for patients to have a spontaneous appreciation out of their mouth, looking visually at a photo of their own self on a big screen. Whether your imagery actually have a 3D transition or even as simple as this particular overlay on screen, the communication of what it can achieve is very powerful. Orthodontists will love it because now you're communicating more closer to how they would treatment plan and how they would visualize things, rather than back in the days of what they would call using a case-link setup and try to move teeth on the model before, hang on a minute, we're actually moving teeth in patient's mouth, and this is not what it seems. But coming from a restorative dentist, I would highly recommend that you need to look at this particular image as with a grain of salt, and as your clinician, you will understand that, oh, look at this papilla, for example. If I were to rebuild this tooth to this particular shape, I will need to push or puddle that papilla to close it. And yes, that triangular space will be there, but where is the crestal bone? If I were to imagine this outline for the zenith, where does it end? I mean, this particular case, as we see on the photograph, seems to have a medium lip line. That's not to say that the patient can't smile more. But for argument's sake, let's say they have a high lip line. You then have to actually apply your clinical knowledge that the patient is not aware of. All they see is this wonderful photograph, and this impact is like, oh, I want this. As great as a communication tool, though, you have to marry up what realistically, in your experience, your clinical experience, what you can provide as the final outcome, so that you are not in a different platform of that imaginary expectation that, when patients see this, they join the dots in their own mind of what their final outcome may be. But this is certainly something that you could check on parameters such as midline, the level of teeth display, the shape of the teeth, so many validations you can get, and it's a very useful and very powerful tool. And again, these information can further be relayed across interdisciplinary to your laboratory, to the patient, their family members, etc., etc. What's more, even better, is that you could then generate models from these diagnostic wax up, just as physical models that we may perhaps be once used to. And in cases where applicable, once these models are generated, you can easily still make up a putty guide and then do a physical try-in in patient's mouth, rather than just, again, now having a photograph in that is just diagrammatical with outlines. You will then, as clinician, perhaps at that point, realize, oh, hang on a minute, how much soft tissue are we dealing with here? Or from a patient's point of view, as the overlay gets put on to their existing dentition, they may then see a bit or appreciate a bit better where certain things would need to be modified in terms of their actual expectation on the outcome.
So Agnes, just a quick question from the floor. If I interpret that question correctly, 3D computer generated or digital mock-up or wax-up versus manual wax-up.
Yeah.
When would you choose for each? Is there a time that you would clearly see a benefit, perhaps, of one option over the other?
Okay, so I think every operator is different, and so your own personal experience, you gotta find joy in what you do. So I think that if you're the type who love working with your hands, and because you need to come across with the patient that you love your work, and you are able to express what you're trying to convey, and whether you are more comfortable in the zone of the digital space, it is up to you. But sometimes I do find that if you just use a photograph and it's something fast that you can generate, the danger zone of just leaving it as a photograph and then off on a tangent to plan, especially quite an extensive case, without further validation points of generating a model, doing a wax up, trying, etc., it's a little bit risky. So it also depends on who you need to communicate with. If you're working, so my understanding of my colleagues as well, if I'm working with someone who much prefer their appreciation is a digital sense, such as an orthodontist, then often I will choose to communicate with them, and it's so much more easier to generate a letter, much easier than if I were to do a setup, etc. On photograph with just an overlay of two sides, even if it's just in 2 dimension, because I know that this is effective communication to the person I'm talking to. That doesn't mean that I have to go out of my comfort zone if that doesn't help me further visualize what I have. It is also then a communication tool for me to also pass on to my ceramist or technician to then, can you give me a baseline of an actual diagnostic mock-up when the time comes, or if I feel very bonded with the case, which many cases I do, I actually do my own diagnostic wax up, which I can continue to feed in this communication through with my orthodontist, for example, as it comes along. So you have to remember that whichever tool you use, you have the person who, the purpose of this tool. So if your communication partner is someone who relates things digitally, then that could be a way to really get the message across. I do find that as I work with different programs out there, actually, sometimes even maneuvering the model on screen 3-dimensionally, depending on the transparency of the image, or how to enlarge them or spin them around. Sometimes that visualization is actually very abstract. So in one program looking a bit more confusing, in another program just because the transparency is a bit different, suddenly you think, oh, that looks much better. And I'm sure plenty of you out there who's used different different planning tools out there, co-diagnostics or DTX or Simplant. You visually you get accustomed to these particular images and programming, and you develop different skill set. And that's why I highly stress it's an experience for both end. But I want to highlight the word experience as in your actual skill experience, what you think you see inside your mind, but what you actually present of your views to the other person who you're trying to communicate, whether this is a patient or another colleague that you work with, or your laboratory technician, because they can't read your mind or see what you see. They just see what you present to them. Or if you asking them to help you devise a mock-up, or you're asking the lab to help you do a digital mock-up, you have to be able to give them specific references to begin with. You can't expect, oh, look, can you just make it look better? Those look better just means so different things to everybody. So as we come to this point, digital mock-up also have great abilities to translate to other utilization. But before we bridge that gap, what if the situation is patient has no teeth? So patient has no teeth, or they have very compromised teeth. Sometimes the mock-up stage can be utilized with the help of removable appliances, not like a full like acrylic denture that you have to make up, but similar process where you could take original model, form a base plate, where you can then have teeth overlay on top. This is a great tool again to be able to confirm if you have missing teeth, which is the topic of our interest today, planning for missing dentition. You can actually check your incisal edge position. You can check reference for phonetics, incisal edge comfort, lip support, and then from there, the rest of the occlusal plane. Once the patient is actually restored something or temporarily replace something that they are missing on the upper member, on the maxilla, you will actually also observe that facial comfort and that adjustment, almost spontaneous, of that vertical dimension at rest, to then assess the level of OVD change that is required, the amount of restorative space that you may have or you are able to reorganize or restore, etc., to then come up with the final plan where you could have a common end goal to then work out how will we be able to deliver that type of teeth replacement for that individual. But notice that that common visualization is so important at the beginning, which then you work out how you can hold those stages to take the patient along the way. And once you have these information, so whether it be in a diagnostic on a model, something that you've carried and captured from intra-oral mock-up, whether it's with a scan or with a physical model, once you are able to have that diagnostic template, you will then be able to actually overlay this information to what is available to us now on digital format into radiographic mock-up. So of course, in very simple cases, many planning program now, you could even mirror image a contralateral tooth across to just, if you're only dealing with a single missing space and you're not reorganizing occlusion, you're not reorganizing aesthetics. But of course, in cases where it is more greater span, and we're now talking about changes in OVD or greater span, such as this case here, your diagnostic denture could be duplicated. And in this particular case, you can see that there are some GP markers that are there. That was one of the earlier ways that we put in radiographic markers. Today, you could actually, without duplicating the patient's denture, if you can synchronize your scans relatively close at hand, and with scanning tools, you can actually just put radio opaque resin blobs onto the denture, and they will then go for their scan, and you will do your double scan of that denture. And once they have finished those two exercises and you've got the files, you can then just quite easily remove those little resin blobs that are on top. So it saves you a little bit of work, for example. But the concept is there, that you could actually have these radiographic data of the prosthesis or of the template that you're trying to do. Once you're able to have that, you can then, of course, have your implant planning digitally on your cone beam data. And as you know, I was trying to explain to you before, it's like looking through a hologram. And not many of us, or as at least I have met enough people, along the way as we explore the utilization of these programs, to know that visually, our appreciation of each of these images are quite different. As we rotate it around, we are now also able to overlay that prosthesis on top. we can spin it around. We can actually reduce the transparency or option to see only the outline of the prosthesis, so that we can assess things like restorative space. Now from here, what kind of flange are we talking about past the platform? In this maxillary case, what are the different prosthetic options aside from the number of implants that this patient can actually have, whether it has to be bar overdenture for hygiene reasons, or whether the emergence actually allow us to actually have a fixed prosthesis that patient can consider also as an option, etc., etc. Also, radiographic mock-up allows us to further from here to plan surgical guide as well, so that there could be more precision control as to where we want our final implant position to be in relation to our prosthesis. And we can also decide where anchor pins go, whether it is a tissue guided, or whether it is a bone fitted, or whether it is tooth fitted guide, etc., etc. And here you can see that this is a tissue fitted guide with anchor pins that has been utilized. And so those are the different ways of visualization, and these visualization remembering is helps a developing clinician or even an experienced clinician to be able to convey what they see with other people, such as the patient and people they work with. But more importantly, be able to be on a common platform as we move along to these to achieve the final outcome. So,
thank you so much, Agnes. Very comprehensive cover of the variety of different options that we have with visualized outcome. I guess to summarize, I think there are a number of tools that, as a clinician, that you have to communicate, to assess, to diagnose, or sometimes co-diagnose for the intended outcome in mind. These options can be used individually or sometimes synergistically together. There's no reason to say you're only limited to one or not both. Like the question asked previously, which is better, digital versus analog, wax up? I don't think there's a big difference between the two, but what is important is, like Agnes said before, is that you should transfer that information intra-orally first to test that out. As long as you test it out and you have and you can see intra-orally that it works, then it doesn't matter whether it's digitally or otherwise that you obtain that shape in the first place. I don't think that makes any difference whatsoever, whether you want to do it yourself or your technician is going to do it. I'll just quickly cover one question that was said earlier about the intra-oral mock-up, how previously one of the canine was quite long, but how is it after the intra-oral mock-up the canine did not appear to be so long? Actually, in that case, we actually lengthened the from 2 to 2 quite a lot to make it actually in the even length as the canine. I know it doesn't look like that in the mock-up, but that's actually what we did. An alternative way of doing it is use a black texter. So if your canine is too tall, the rest of your anterior mock-up is not that long, you can use a black marker, just temporarily mark out that tip of the canine. So when you take a picture, right, the rest of the mouth looks a little black, and so you give the patient some sort of idea that that canine is not that long.
Some people are very afraid of black markers on their teeth, but if you dry the surface really well, even a graphite pencil, like lead pencil, that bit of gray already able to give your eye a visual reference of where that is.
Yeah. No, thank you so much for all the wonderful questions, ladies and gentlemen. I will again, at the appropriate time, I will be certainly directing as many questions I can to the panel. There are just one or two questions which may not be pertinent to the topic of discussion today. So my apologies that if I am not answering some of those questions because of the limitation of the time that we have today. But you can certainly reach out to me in private later on to our send us an email, which is to the Sydney Prosthodontic Group email address, and I'll be more than happy to answer any questions that we may have. So now that we have some idea of visualization, And again, before we're just going to jump into any particular treatment or particular planning, let's again take a small step back and looking at the reason why. And also quite a number of questions has been asked by the audience already regarding why. Because teeth are not lost because of the same reason. And because the causality or the etiology of missing teeth is different, and therefore we have to be very, very certain that we're going to manage the causes first. Because if we don't manage the cause of why the teeth were lost in the first place, and we're just going to, again, doing all this wonderful dentistry, who's to say that our dentistry is not going to fail in the same manner? So Johnson, if you don't mind, could you cover with us some of the most common areas of the etiology of why teeth are lost?
Great, thank you, Ben. There are a number of reasons why teeth fail. One of the common reasons would be any of the parafunctional habit. Nail biting create a lot of forces that generally tends to break any restorative material on the upper incisors. Every time any restorative failure, it's important to let the patient know that, if there's still remaining restorative material there, this is due to the shear fracture. So it's important to check whether they have any habit and check their nail to ensure, you pick up their biting their nail, and to stop nail biting. Harmful eating habits. One of my good friends loves eating pistachio, especially the unopened one. I did an implant crown for him back in 2009. I remember having to retighten a loose abutment screw pretty much within the first year. But after a few times of retightening, it's not until about 10 years, he asked me, oh, would eating an unopened pistachio cause the implant crown to loosen? And yes, I said, oh, definitely, you should stop eating, unopened pistachio. Well, at least not on the implant side anyway. And then recently, he cracked the opposing molar on the contralateral side. So the good news is implant crown hasn't loosened, but he cracked another tooth, vertical root fracture. So hopefully he will stop eating. Yeah, pretty much, right? The other one is not obvious, but is a chewing pattern. Most of patients, when you ask them to close, people close gently. But some patients, they just like chomp like a champion when you ask them to close. And sometimes it's a discussion whether they can change their chewing habit. But other times, I have this patient telling me, well, I've been chewing like this for 70 years. I'm not going to change, right? So this is a patient in the 70s, and then basically he's wearing out his teeth significantly, and he's got a number of missing teeth. And we can see his chewing pattern is exhibiting more wear on the left-hand side. So our aim is to increase the occlusal vertical dimension. When we increase the occlusal vertical dimension, we want to start as early as possible before the implant surgery, so that gives the patient a bit of time to adapt, to use to the speech, to use to the chewing. But most importantly, we can monitor the wear or what the parafunctional habit is like. Some patients, they see this as a second chance, right? So they'll be quite gentle. Other patients, they just go back to their old habit, right? So this is after about 9 months. We can see this patient just goes back to the old habit. He's of the belief that I'm having all this rehab to improve my chewing. I'm not going to change my habit. So basically, if we compare 9 months when I did the build-up versus 9 months after, there's a significant wear. So there's two ways you can approach this. One is, for the final restorative design, you can copy what he's wearing into and hoping, it will reduce the complication, porcelain fracture. And of course, you need to wear an occlusal splint. So when we can't change the habit, then we need to do our restorative design into the habit.
So here's a very, very good question, Johnson, to using your case to illustrate. Maybe there's two questions there. One is, how do you what if, I mean, here we can see that the composite had been worn a lot. Now, during that period of time, was the patient wearing a splint?
Patient was wearing a splint, but it's due to his daytime.
Mm.
We always give them a temporary splint after composite build-up, but it is due to their daytime parafunction.
Yes. Yeah. Now, assuming that it's a different case.
Yes.
But this time there's insignificant awake bruxism.
Yes.
But there's primarily sleep bruxism.
Yes.
Hypothetically.
Yes.
And you give the patient a splint. Now, the question here asks, what if the patient's in denial and they just don't want to wear it?
Oh.
In other words, I'm guessing the end result is there's excessive wear.
Yes.
And potentially even fracture.
Yes.
So
yes.
How do you again, it's got to do with the management potentially, right? How do you initially communicate that requirement across?
Yeah.
How did you control it?
Yeah.
And how did you deal with patients that just go, I'm just not going to wear it?
Yeah. I think initially, when you talk to most people just have to. Recent people will say, well, I don't know whether I'm clenching during the day or whether I'm grinding nighttime because I'm sleeping. But they are open to suggestions, right? So once they're open to suggestion, when we start the restorative work, we want to tell them every time if there's wear and tear of their restorative material. So we want to re-educate every time. And then, but of course, it's very important to pick the right patient. If they're in denial, that from day one, they may not be the best patient to treat.
Yeah. Screen out the patients that is potentially in denial and that I guess they just may not want to help themselves to some degree.
That's right, because they may come back to you and say, oh, well, your restorative material is too cheap for my jaw, right?
I think sometimes there has to be a distinct difference between what you consider someone's in denial or they are honestly quite unaware.
Yeah.
So in patients who are actually receptive of your opinion, that's why they come and see you for the consultation, and as you make your observation and you let them see, like these are the evidence of how things are wearing and tearing in your mouth. Now if you don't think you have been doing it throughout the day, then the chances is you may be doing it at night. But how frequently or what time aspect it has been happening, we don't know. And for those who are a bit more reluctant to doing a splint, I find that if they're happy to take it as an exercise, like a self-experiment, because in the end of the day, if they take it as an exercise that they do wear it every night, and you put the onus back onto them, wear it every night, and at the end of 1 or 2 months, you may wish to bring it to me so I could help you look at it together. But all you really have to do is turn that splint around and have a feel of it yourself. Because if you have been doing wear and tear, you'll be leaving marking like tire tracks onto the appliance itself. And that's sort of like, that would be the most objective indicator of what potentially you could have been doing at night. And I find a lot of my patients do take onto that if they are actually receptive and have that understanding behavior. Like, these are patients that I quite happily work with.
Great, thank you.
Good, thank you. Awake bruxism is also as common as sleep bruxism, but it's often without people's awareness. This patient fractured his implant crown or abutment screw when 3 times. It's always very challenging to retrieve fractured abutment screw, but it's not until the 3rd time that the patient realized that when he's a bit upset, especially when his sports team loses, he moved his jaw to the extreme right and then crunched down on the implant crown like a peanut. And this is what we can see with the implant crown, how he fractured the abutment screw, and then it's always tricky and challenging to remove a broken abutment screw. Now, if you watch this video, you can see every time he's chopping down his Mr. filing. If you are going to ask, most people are always don't realize they are clenching during the day. As part of our assessment, we always check the chemistry of the Mr. Muscles, and then I always love to comparing that with a patient's like biceps, right? If the Mr. is quite hypertonic compared to their biceps, and I let the patient know usually there's some form of a bruxism, dental parafunction activity.
And Johnson, any advice that you would give to help the patient to control awake bruxism?
One is to self-recognize, and second thing is we can always get them to do a more reminder system where they is setting alarm on their mobile phone, or putting a rubber band, sometimes writing in their hand, or putting a sticky note in front of the computer as a reminder system.
So anything that they can see, they can feel,
yes,
or possibly they can hear,
yes,
as a constant reminder to increase that personal awareness through just repetition every single day.
Yeah, definitely. Yeah, but of course, should they be unable to control that as some of the patients, then Botox could be one of the very last resort. Who keeps on fracturing any of their teeth.
Of course.
Yeah, and then we go to sleep bruxism. So sometimes patient come to us in early stages. For this patient, he came in when he's losing a significant amount of his tooth surface. And this tooth surface can be better visualized from the occlusal view. We always give the patient option of either saving as many teeth as possible, or saving the teeth with good prognosis. This patient decides to go for saving teeth with a good prognosis due to limited finance, and he also would like to have a treatment plan that will enable him to not worry about his teeth for the next 5 years at least. So in this case, we've decided to extract basically a majority of his maxillary dentition and some of his mandibular dentition. When we don't have any anterior teeth, or when we have a large number of missing anterior teeth, the partial denture option is no longer retentive. So we discussed the option of implants retained overdenture, 2 implants versus 4 implants option. Scientifically, 4 implants have less complication rate in the maxilla, but due to limited finance, he's decided to have 2 implants with locators, which helps to retain the dentures when the patient chew in the anterior region to prevent dislodgement. In the mandibular, we did a traditional partial denture. And with the implant overdenture, the locator inserts, we can pick different strength. Usually, if we just have 2 implants, we need to have a more retentive one. And we are able to give the patient a very nice result with an even occlusal plane. So in this case, we increased the OVD, and it was tried out in the provisional denture phase. Teeth can also fail due to periodontitis. This patient had a severe periodontitis affecting the maxilla and the mandible. While we can try to save the teeth for as long as possible, patients been under the care of a periodontist for the last year, but it is the poor aesthetic result that is a concern to the patient, that the patient decided to have the maxillary clearance. We discussed the option of a fixed prosthesis as opposed to the removable prosthesis, but due to there will always be some pathogens in the mandibular arch due to the large volume of bone loss, and the need for pink porcelain. If you decided for the fixed prosthesis, patient decided to be on the removable prosthesis for the ease of cleaning. when we do the implants retain overdenture, we can remove the a little bit of the roof of the mouth, so the patient can taste the food a little bit better, and also doesn't affect the speech as much. And we're able to provide the patient with quite a nice result. The true surface loss or missing teeth can be also multifactorial. It can be a combination of a daytime bruxism, could be nighttime bruxism. For this patient is a combination of both. We also have to deal with other factors, like this is a severe class 2 diff 2. Different to class 3 cases where when you open up the occlusal vertical dimension, you can convert them into a class 1. Often when you treat with a deep bite class 2, when you open up the vertical dimension, the lower incisors is further away from the upper incisors. In this case, patient was biting the gum, so it's very important to let the patient know before we start the treatment that missing teeth needs to be replaced. But also when we open up the occlusal vertical dimension, the palatal aspect of the upper incisors will be a lot thicker, and then we'll need to thicken up the buccal aspects of the lower incisors. And after all the discussion, right, due to patient is a severe daytime parafunction and sleep bruxism, we decided to use a more monolithic zirconia material, and also based on the patient's expectation he wants a more plain look. He doesn't want to have a more multi-layer appearance. He just wants everything to look same color. And also most of the patient with a diastema doesn't, if it's large diastema, sometimes they still want to have a little bit of a small diastema in between, as they don't want the two incisors to be too big.
Great. So ultimately, we do have to control all these causative factors. Johnson, for your patient of sleep bruxism, how do you think you've controlled that sleep bruxism so that he's not going to wreck the implant overdenture and his remaining dentition?
Yeah. For the implant overdenture, we do a thin bilaminar splint to cover all the locator inserts. That's if provided they are edentulous. But if they still have some dentition, we can do a soft bilaminar material in the opposite arch.
So in other words, using occlusal splint therapy.
Yes.
Question asked, for erosion cases, I know that's not something that we've covered, but obviously we would recommend a fluoride in additional management as well. There's one interesting question that was about actually 2 or 3 questions regarding repeated abutment screw loosening.
Yes.
One particular case said it was a 1/6.
Yes.
Good brand.
Yes.
Everything appears to be sound in
Yes.
terms of emergence profile, occlusion, etc. But for the last 5 years, every year the abutment screw comes loose.
Yes.
So this clinician had to retighten the abutment screw, and he's thinking of changing the abutment screw soon. And he's asking for, she is asking for, what do you think could be the cause for repeated abutment screw loosening?
There are many reasons. One would be daytime hard food eating habit, or sleep bruxism, but most commonly would be the implant size. Often when the periodontists place implant, they like to place a regular platform in the molar region. And sometimes when you send to the technician, if you don't prescribe in the molar region, you need a reduced buccolingual width because of the either the reduced implant diameter or the patient with a parafunction. They might make you a big molar. So basically, that puts a lot of forces in the abutment screw. And we always, and that comes to the prosthesis design. And also we need to ensure the occlusion. We always have a shim stock clearance. But some people, they are a severe clencher. So when you check for the shim stock clearance, you want them to bite hard. If repeated abutment screw loosening, rather than having one thickness of shim stock, you may want to have 3 to 5 thickness of the shim stock to reduce that loading. Yeah.
And also lateral intrusive movements as well. I think that's important. Similar to your case where they bite
And I
in
think
extreme jaw
this
positions.
particular question, they have highlighted that they've screened for protrusive and lateral intrusive movement. But what sometimes I find, especially in very, very nicely anatomically done implant molar crowns, which sometimes actually is not what we want. We want the narrow occlusal table. But do check for medial intrusive interferences in this case as well. So that's by placing the articulating paper over the your implant crown, but asking the patient to clench hard and move the jaw to the contralateral side to see if there is some of these so-called, whether it's balancing contact or actually interfering contact as they go to the other side. So if you haven't yet screened for that, have a look at that as well. And then finally is habits. So of course we are very focused on looking at actual dental occlusal parameters. But if the patient actually have a certain chewing habit, like they have really, really chewy food, but also quite hard, and they tend to still have a preferred side of contact, or that implant crown is where they like to really chew their food, then that alone itself can often be putting that lateral forces, like with that item in between. So yeah.
I guess in summary to that question, what everyone is saying from the panel is that the masseculatory forces has exceeded what the mechanical component can withstand, and there's a lot of different reasons for that. It could be sometimes as simple as the abutment is worn, or the technician even use a non-engaging abutment. I've had that, right? From what Johnson's saying is that perhaps the implant diameter was narrower, so therefore the abutment screw is narrower, or the crown was too large, or there was some other massecular forces. So whatever it is the occlusal forces, it probably exceeded what that particular system is intended to load. So I think check everything. Go back to the drawing board. Sometimes, I have replaced a 2/6 for a patient with no opposing molars, and you would think, well, that opposing 6 should not have any contact. There should be no mechanical problems. And then she came in with a mesobuccal porcelain fracture, and that was because of daytime parafunction. When you ask her to go into centric, lateral excursion, protrusion, I guarantee you there's no contact. But sometimes a parafunctional occlusion is not your centric or your conscious occlusion. So I think sometimes we do have to educate our patients about that. And the last question before we go for a quick break, Johnson had said this is a very interesting situation that this particular clinician has cemented in these crowns. I assume, I'm not sure what crowns it was cemented, but it was using Fuji Plus, so it was a resin modified GIC, but the patient feels that it was detrimental to her health because of the fluoride that it contains. So she wants her new zirconia crown cemented by cement. I assume that's a resin cement, and not containing fluoride and eugenol. Do you have any concerns with that? I guess it's about using fluoride, not cements or resins not containing fluoride. I'm guessing the answer is yes. So for your zirconia crowns, for example, what cement system did you use, and do you have any concerns with using fluoride?
Basically, Americans like to use the Fuji. They cement it in, but others like to bond it in. When I use the zirconia, I like to bond my zirconia in, so I use a dual cure resin cement. I don't have any concern for the no fluoride releasing. Like the fluoride releasing in the Fuji is it's not that much.
Right.
Yeah.
Do you always prescribe a splint, even if the patient is not perceived as a bruxer, but you did carry out a full mouth rehabilitation of some sort?
Yeah. For most of the full mouth rehabilitation, unfortunately, they're all tooth-wear cases. So I prescribe almost 100% of the time.
Yes.
Yeah.
Yeah. According to the and one last question is the abutment screw. Coming back to that, is that if the abutment screw comes loose, do we need a new one? According to most manufacturers, I think the answer is yes. But I think certainly you can be you can apply that depending on the case. They're worried about particularly the narrow ones that you may break because it's already suffered enough plastic deformation, or the head of the abutment screw may strip. Of course, we all had that problems before. But typically for your wide platforms, it is certainly slightly harder to break or to strip. But do exercise your clinical judgment. But I think again, in theory, it is recommended to do so. So thank you for your questions, ladies and gentlemen. We have not finished for this evening. We're just going to take a quick 5-minute intermission break. And when you come back, we're going to go through all about the options of management of missing teeth. Welcome back for the rest of the session. We'll pick up from where we left off. Of course, the first session we covered more about holistically speaking in treatment planning, and now we're going to go into the nitty-gritty details regarding how we are going to replace our missing teeth. And as we all know, that there are so many different options. So it is going to be another jam-packed session coming up. But sometimes not all teeth needs to be replaced. We've seen plenty of patients with one or sometimes even multiple missing molars, particularly for the shortened dental arch concept type of patients, that they may be aesthetically and functionally quite happy with where they are and still maintaining quite a stable occlusion. So Zoe, do you mind going through with us some of the strategies that we have, whether it's no replacement of certain teeth, and I think even with using some of the removable options?
Sure. Thanks, Ben. Of course, the first treatment option that we have to give our patients is no treatment, only indicated in cases where you feel that the patient is occlusally and dentally stable, even though, like Ben mentioned earlier on, with shortened dental arch, they might be missing a number of teeth, but there's a stable occlusal contact, and they're functioning fine. There's no significant issues that we need to be concerned with, what seen earlier with parafunction, bruxism, sleep bruxism, awake bruxism. Then a no treatment option is reasonable, and it is often offered as one of our treatment options in the treatment letter we provide for our patients. Now, when we come across those cases, and most often you'll find that patients might come for a query, or they're concerned about something, but they're not quite committed to treatment yet for financial reason, or for maybe time restrictions, or they don't really believe that there's an issue yet with their dentition. So we have to be careful with people who may elect to have no treatment, thinking that, okay, well, I'm reasonably fine now, but like there's nothing really strikingly wrong with my dentition. I can function okay, and I don't really want to invest that much money and time into my dental treatment. So with these cases, you really need to emphasize the importance of the preventative strategies that we've seen earlier. We've seen what awake bruxism, sleep bruxism have an impact on the dentition. We've seen these patients with parafunctional habits, sometimes even with the reconstructive work. So they're not only damaging their own dentition, but they're damaging the work that we've done for them as well. If we pick this erosion factors, dietary modification, other things like periodontal disease or caries risks. So we have to go through those preventative strategies in all cases, and make sure that we actually document all of those, and make the patient aware that no, there isn't actually an issue. We should really do something about it right now, even something simple like a splint. So for this case, for instance, our patient turned up early on, not thinking that there's a lot going on, but wanted to test where treatment could, if treatment should be taken or not. But despite the recommendation for preventative strategies, you can see in 2013 that which is 5 years later, the same person returns wanting to carry out treatment. But unfortunately, in this situation, there has been a lot of damage to the dentition. There's significant changes in the occlusion, over eruption, loss of teeth. So our discussion with this kind of treatment now, it's kind of started from a new case presentation. Like, we can't really treat it the same way we were planning to treat it early on. So we have to start again, and it's a lot more difficult to manage a case like that. But these cases like this, it's really important to remind ourselves that we have to document everything we've discussed with the patients, all the preventative strategies we talk to them about, and enforce the need for some sort of treatment early on, so we don't end up in a situation like this. Now, if we think about the treatment options for the missing dentition, and no treatment was one option, but something simple like a removable partial denture retained by teeth, that's always an option. And we always have to give the patient that option. For instance, if we look at this case here, even though the patient might be wanting just a removable denture for all sort of reasons, people don't want to invest time, or financial limitation. They had a denture in the past, they might be quite comfortable with a denture. So it's a valid treatment option. A lot of clinicians are comfortable doing something like that. But when we assess even a denture case to improve our success of that denture treatment, then we need to look into the occlusal vertical dimension. Has there been any issues of wear, a breakdown of the dentition? Do we need to alter anything? Is the abutment teeth reasonably sound? Any periodontal disease? So these factors, of course, we have to manage. This case here, there's has been quite a lot of erosion and attrition as well. So perhaps rebuilding the lost tooth structure, using some selective composite addition to some of these teeth that have been worn down, will improve protect these teeth, improve our, we actually strike the gain two advantages. Here we change the OVD so that the loss in the occlusal vertical dimension is now increased. So we have a lot more space for our denture to line up our occlusal plane nicely. Plus, we're preventing further wear and pulpal exposure of the teeth that are already worn down. So we're improving aesthetics and function for that patient. So here you can see that the person can deliver something quite simple with a conventional partial denture. Anyone can do that. It's affordable and easy to make. Now, with our abutment teeth design, sometimes the situation intraorally, there's might be a long span, edentulous span, and the abutment teeth may not actually be well suited for, doesn't have any undercuts. It might be quite slender. It might be heavily restored as well. So we need to optimize our denture treatment to make sure that this treatment is as successful as it can be for that patient. So using something like crowns with milled guide planes, milled rest seats, and also design it in a way that it will enhance our denture seating support and stability. Now, with a case like that, it's very important that you actually visualize your final treatment outcome. For example, when you design your crowns, before the crowns are actually made by the lab, we need to give a prescription to the lab that this is our denture design. We are planning to utilize clasp elements, rest seats in these certain positions. So I'd like my crowns to have the rest seats incorporated into them. Maybe we can design where, say, for example, if you want to have a more aesthetically pleasing denture, then maybe distally approaching retainers on the molars will be more aesthetically pleasing than a mesially approaching retainers. So you design your undercuts on the mesial-buccal cusp of the molars as opposed to on the distal. So you give your lab, this is my denture design, this is where I want to end up. Now let's make the crowns to fit into that denture design. And the lab will make you a framework that you need to try in as well, ensuring that it seats, so it's positively seating into the rest seats, into the guide planes. You know that this treatment is going to work out quite well because we have utilized as much retention as we can from those teeth, but also provided the patient with something that is aesthetically pleasing. There is no visible retainers when we can see on the molars, so patient can smile with a bit more confidence because we were a bit more thoughtful about our kind of denture design to improve our outcome. Now, if you have also some residual teeth that are broken down, now sometimes extracting those teeth might be also retaining those teeth is actually beneficial, especially if they've been endodontically treated, there's no sign of caries, there's no periodontal involvement. So we can use those root stumps, if you like to call them, or retained roots, and seal it and actually use it as a denture stop. So it's acting as a two advantages for that is, first of all, we're preserving as much bone as possible around the side. Therefore, we have a better support for our denture from a better ridge form. Also, it's acting as a stop to preventing any sort of tissue impingement under the denture or trauma to the tissues. And we also can utilize them to use something like a gold cap with like root caps that might have like a ball retainers or locator element incorporated into it, so the lab can mill that for you or cast that for you to improve the retention. And we know from studies that that research into dentures that have utilized retentive elements as opposed to dentures that have not utilized those, they found that masticatory efficiency has significantly improved, as well as patient satisfaction. So think of it similar to implant treatment where you use that retentive elements. But of course, you've got to warn the patient that it is a treatment. These teeth are, of course, they to the end of the journey pretty much. They have to be extra cautious with oral hygiene, regular maintenance to ensure that the longevity of those retained roots can be prolonged, and then hence actually the carried out treatment can be prolonged. So this is here we can see the allocator incorporated into the root cap, and then you can use that with an insert into the denture. And this is the case there where you have utilized the locators and then the root, the sort of kind of root stumps, if you would like to call them, for support. And some of these better, longer formed root-shaped teeth for the canines, they have been utilized with root caps and locator elements. Now, another option for treatment with a removable denture, partial denture, that is we can utilize dental implants. So we might not have sufficient abutment teeth in those cases where we still need to look into alternative options to improve the denture experience for our patient or improve their quality of life. So, for example, if you have a look at this X-ray here, you can see that in the maxillary arch, patient is missing quite a large number of teeth. So she's missing 2.1 to 2.7. This is a unilateral long span edentulous area. Having a conventional denture, removable denture in this situation, which is similar to a Kennedy class 2 situation, we kind of know that we will have some issues retaining that denture. First of all, the issues might be, or we might be looking at the first abutment tooth here is the central incisor. We don't want to have any retentive elements sitting on that central incisor. It will be aesthetically unpleasant for the patient. Plus, with the long span edentulous ridge, we know that the retention is going to be unsatisfactory for a denture. So if we are to use this case and think about how can we maximize what we have here, patient can't afford expensive implant treatment or multiple implant treatments, or even a fixed prosthesis. How can we make it work for someone like that? And thinking about adding 2 implants to the edentulous in the edentulous span, well spaced out implants, it will change your class 2 sort of Kennedy class 2 classification to something like class 3. If you think of these implants similar to an abutment tooth, except it's now you providing an additional retention as well as support for that denture patient. So we can connect locator abutments to those implants, and in this case, that's how it presents intraorally. In this case, we have provided the patient with a prosthesis that is removable, it's cost effective, but it also has no palatal coverage. So the patient can taste food a lot better, have a more comfortable occlusion, a more comfortable prosthesis in their mouth, and have ended up with something that you can see here. It's sort of seamless. It blends into their mouth. There is no retainers on the central incisor. It's quite retentive. We wouldn't have been able to do that in this way without utilizing implant for the denture retention. Now, even in cases where it's okay, you think this is a class 3 Kennedy classification, we've got well-distributed abutment teeth, distal abutment, as well as more mesial abutments. In this case, do you really need implant for retention? And sometimes no, sometimes the answer might be no. We quite comfortably provide a patient with a denture that does not require implant treatment. And in other situations, having these 2 additional implants in the premolar sides means that perhaps our abutment teeth are heavily restored. Perhaps you don't want to use those abutment teeth to place a retainers on, an unsightly retainer for someone who has a very high functioning lower lip that will display aesthetically all form of like with lip movement. So if we design our denture with this, we have improved our retention with the locators, but also eliminated the need for having any additional retainers on the canines. So aesthetically, you can see here that it is a lot more aesthetic because we're not having that unsightly metal show. Plus, it's a lot more retentive, and we not relying on the shape of our abutment teeth that might not be retentive or heavily restored. Okay, we've seen this case earlier for the Kennedy Class 4 classification, and you can. This is an example of a case that if we don't utilize implant treatment, then this patient is unlikely to have a partial denture that will be retentive and comfortable. Because if we think about the fulcrum of rotation between the distal abutment teeth, it's quite far distally. That means the denture from anteriorly will lift and move as the patient incises into food and chew. Because of the location or position of the abutment teeth. So in this case, then someone like that may end up extracting the remaining abutment teeth and having a full upper denture. That way you can have a palatal seal, establish some saliva, suction saliva, or utilizing a couple of implants like we've done, that is more cost-effective, economic, then we can offer that patient a removable style denture that is partial, doesn't have or does not need that palatal coverage, so it's a lot more comfortable, but it's also retentive, and we know from studies that utilizing implants and denture treatment significantly improves the patient satisfaction, quality of life, and masticatory efficiency. They're able to generate greater forces and distribute those forces alongside the denture, not just where the abutment teeth are. And that's the result.
Yeah. Thank you, Zoe. Excellent tips and tricks there. One very interesting question I'll throw to everyone in the panel, probably starting with Zoe, is that we do sometimes get cases where it's complex. There could be lots of missing teeth with a variety of different reasons. Any advice on how to simplify your presentation, your case presentation or discussion process for the patient?
Mm-hmm. Not all cases, quite often, sometimes they come in and you scratch your head, where do I start? What is the easy way to convey my message across to the patient? And is my system, like thought process, is systematic and logical? So quite often, if we're uncertain, then we always have to take study models and photographs. So laying these photos on a big screen and looking in front with the patient to discuss these issues. Always assess the occlusion, assess restorative space. So these are the things that I would like to see initially. When a patient turns up, I'll look at the face, assess, are they overclosed? Are they reasonably satisfactory OVD? Then assess intra-orally, what's the situation of the dentition, which teeth are to be kept and which teeth are not so satisfactory or doesn't have a good long-term prognosis that we may think of sort of getting rid of or replacing in the future. Once we worked at that sort of situation and looked at the photos on a big screen that will make things a lot more clearer for us, then we can pick on the aesthetic limitation and boundaries and issues that we need to fix. Then have a communication with the patient. Okay, well, does that bother you? Like, are you bothered by this or not? And the patient can guide us sometimes in the direction where, okay, well, I don't like the look of this. I don't like how my smile looks. Or I don't like my teeth. They're sensitive. Then always, I like to take some study models. I know where my OVD, for example, if it's reduced or if it's satisfactory, I'll like to take study models and then go by that in terms of your diagnostics, set up trial dentures, wax up, and design some sort of, start with something as simple as possible if you're not sure. It's not wrong to just make conventional dentures. Let's do this. Maybe a conventional overdenture, even if it's overlay some of the occlusal surface of the teeth. Maybe a trial splint to work out, will that patient be better off having received that treatment or not? So having some sort of conservative,
more minimalistic,
and then you will find that with time, as you've done all of these sort of tick boxes kind of steps one by one, you're kind of coming to the realization like, okay, well, now it's a lot more clearer that treatment plan is heading in that direction. And then you can look into, okay, I can replace these missing teeth. We need to change the bite because your bite is a lot better now. You can eat, function better. And then, okay, we have missing teeth. Maybe we can look into denture or fixed option to replace them.
And I think it also goes into how we started the webinar with visualization and talked about the experience. And I think when, some way to, there are a multitude of ways to of treatment options, and some would be more the clinician's preference, actually, I find. But when relating to this audience question of simplifying the case presentation.
Simplify is the key word.
Yeah, and also the patient is already presenting with multiple failing teeth. I often find that, patient will come in with a specific concern. And as a clinician, we can focus on addressing that concern. But as that clinician actually have greater experience to visualize actually what are the background risk factors. And of course, you can talk to the patient whether they're receptive or not. But the end question here that sift through simplifying the presentation of case is actually finding out from the patient what kind of quality of life and expectation do they want as they are embarking on having multiple failing dentition, as eventually what they visualize themselves, that consequential journey. Can it be taken as a stage approach? Is it correct that with their expectation coming here now to see a specialist, where they expect treatment is a bit more complicated and maybe often, it would cost them more than what they usually would expect in their day-to-day dental work. Because if their expectation is replacing this aspect and this is their major dental work, that one stop in life, and yet they, as you talk to them about the risk factors of other potential things that may or may not involve other dental intervention per se, but if there's no concept of looking after holistically, I feel often I would throw it to them, well, which are the strategic teeth in the bigger picture would you actually want to retain, and what type of procedures and outcome would you like to embark on, and take the conversation from there as to how to stage those events into what I think this question is on about, is as they are going into terminal dentition per se, or multiple failing teeth or longer span. So I think knowing what they expect as their experience is helpful for you to cut down on what type of options.
So discussing to the patient to find out how they're picturing the end goal. I think talking about the budget is really important. The majority of the viewers here will be in private practice, I would assume. So ultimately, the patient has to pay something. And if you're going to throw big treatment plans for them that there's no way they can afford, there's not much point talking about that for a long time. So I think finding out their budget or their expectation, I think is important. I do find patient education is very important, because often patients don't understand. They know that they're breaking or missing, but sometimes they don't know why it is missing and what complexities there are for us as dentists to do it. So when they have a good understanding of the problems, then they're beginning to appreciate the complexities involved. And sometimes then in their mind, the budget just actually went up and they have started to accept that, or all of a sudden a little bit easier.
And I think even with the cases that Zoe presented just now, both are candidate class 4 in the maxilla. One option is to do mill crowns on the posterior molars to have a mill partial denture. The other option, where the teeth were actually quite pristine and minimally restored, was the option where patient has ended up choosing the 2 anterior implant to help with that retention. Now, both modality may be presented to the patient. One is where conveniently, if those teeth would benefit from a crown as well, and the prognosis of those teeth, because if those teeth goes, then it will pretty much be a edentulous situation. Whereas if on the other spectrum, teeth are relatively okay, they don't exactly benefit from a crown on their own sake, and if anteriorly you place the 2 implant progressively, as he or she lose other posterior dentition. Not to say that you could just have a full denture still with an open palate with only 2 locators in the front. However, it is something that they can then interwoven if they are lasting for their next phase of their rehabilitation. So I think that's why sometimes staging, talking about where the patient's end goal might be, would help you devise how may you even design those fixtures at first, whether they could be utilized in an next option, etc.
Thank you, Agnes. And just quickly answer one particular question. Yes, for those implants that's placed in the overdenture positions, they can later on be converted to a fixed prosthesis. That's under the assumption that the clinician who placed the implants have taken that into consideration, that the angulation and the positioning is suitable for it. But yes, all the cases that we do, I have that in mind. So let's move on to some fixed options. This is looking at, I guess traditionally we call these fixed bridges, supported by teeth, and a little bit later on by implants. For most of our undergrad training, I'm not sure about our viewers at home, but I was by and large taught how to use fixed connectors. So for example, your traditional 3-unit or 4-unit bridges, everything is in one piece. It was only until sort of specialty training where I'll be exposed to more using non-rigid connectors, as in a 2-piece or even a 3-piece bridge for a longer bridge work. And the concept there is the reason why sometimes it's advantageous to split up your bridge into multiple pieces is because teeth roots are different. Some teeth move more under load than others for a variety of reasons. Others because if this bridge crosses the midline, particularly for the mandible, mandible does actually flex when you open. And so you want to give that bridge prosthesis some give. And last but not the least, that the longer the span of your bridge for the same amount of load, the cubed the amount of vertical deformation on your pontic. So what we're trying to say is that when a bridge, the longer it is, the more teeth could be mobile, or one abutment or more is mobile, is that your things are going to move underneath if everything is joined together. And if things are going to move, then of course your cement is going to break down more likely for caries, or for your porcelain to fracture, or even the metal for fracture. So in other words, your prognosis reduces. So therefore, when you look at most these large commercial bridges, is that they have all these stress breakers, physical stress breakers. Not many bridges that you see or drive on has just been made out of one large piece of concrete. And you have all these things you drive on, you're hearing the clunks over the bricks, and that's because that there are inbuilt stress breakers, so that when, say, during hot days, things are going to expand, cold days, things are going to shrink. When a heavy weighted train or truck that drives through it, right, there's a lot of movement. So therefore, the pieces of the bridge, there's allowance for these jigsaw pieces essentially to work, move somewhat independently, but they all work together. So same thing goes for teeth. Whenever possible, and you are dealing with multi-unit sort of bridge, take this case here for example, you got missing already 1/6, 1/5, and the teeth 1/7 and 1/4 are already crowned, suffering from caries. Now the patient would like to have a 4-unit bridge, similar to the bridges she has in quadrant 2, because she's very used to it. So first we will take off the abutments, take off the existing crowns, we will tidy up the margins, and as you can see that I did not parallel up these two abutments, and the teeth can be prepared or retained to carrying their own individual path of insertion. So that's one benefit of using non-rigid connectors, because the two pieces of the bridge are going in their own path of insertion, cemented individually. Where first you got a crown on the 4 with a distal slot, and then you got the distal piece sliding in subsequently into place. The majority of these cases should be done using PFM, so that your connector can be small, that small metal island, and without too much chance of fracturing. But from a buckle point of view, it can still be fairly aesthetic. So the benefit here is that you don't need to over prep the teeth. You can prep the teeth on their own, using their own individual axes. You can allow for these teeth to move independently, particularly in this case the posterior segment, and therefore that would reduce the flexion of your bridge, generally speaking, because there's now a stress breaker in place, and therefore that could improve to the prognosis of your of your bridge. And last but not the least, if the distal portion needs to be replaced, now you just need to replace that particular part as opposed to the whole thing. So keeping things a little bit cheaper to replace. Not all teeth, in terms of replacement, sometimes you need to put in an implant. There are a lot of cases that we have replaced over the years using a Maryland bridge or a resin bonded bridge. Ceramic has been around for a long time, which we'll talk about next, but there are some cases maybe using even a traditional metal, a PFM version, may be beneficial. So if you are still enjoying doing PFM-based Maryland bridges, do consider using this concept, which is using some slots. So here we are, using more mechanical retention or anti-rotation by, firstly, there are some slots on the palatal, so that's somewhat anti-rotational, and then there are very, very hard to see, but you see right in the mesial of the 1-1 and the mesial of the 3. You can see there are some slots, which is roughly 45 degrees aiming towards the cervical component. So you can see in this bit here a little bit better that you can just see that there is a metal slot, right? And that is pointing in towards the gingival. So in other words, the path of insertion of this Maryland bridge here, it's not inserted flat on from the palatal, pushing buccally. It is actually more from the incisal sliding downwards, right, into the gingival surface. So because of that, there's in other words, we create a guide plane. And so during functional loading, that slot is helping the bridge to seat down further, right? So just like if you're doing some slots into your crown preps to reduce the rotation or buccal palatal movement of your a short crown height. Same concept here, except we're just applying into a PFM bridge. But more and more commonly now, a lot of people are enjoying doing better adhesive dentistry, particularly using a zirconia. Here is a terrific case done by Dr. Johnson. Here we're just using a 1 wing, which is the recommended approach. Select the best abutment that you have and just have 1 wing to secure to. And zirconia can be successfully bonded to tooth when you apply the right protocol. So we do have a previous webinar on the bonding protocol of zirconia for you to check out a little bit earlier. And let's quickly have a look at your options on implants. There's a couple of questions early on about one I think was about the diameter of implants early on, and some on smokers. Diameter of implants, it's a very big topic, really just depending on the case you're talking about. But I think the question previous asking for a molar side, would a 5mm be enough? Generally speaking, I would think so. Something 5 or greater for molars are good. And then another question was about smoking, but it was about casual smoker. There was lots of studies coming out of Italy where something like 70 or 80% of the population smokes to some degree, but they exercise a very stringent protocol, which is smoke cessation. I think it was 3 weeks or something prior to surgery and after. And some of the cases were done using a 2-stage approach rather than a 1-stage approach, and they still got a very high level of success rate. But what they did found is that once the implants are restored and the patient continued to smoke, particularly the ones that smokes more than 8 cigarettes, I think a day it was, they were having twice or 2 to 3 times the amount of horizontal bone loss when compared to a patient who was not smoking. So, it's certainly there's a high smokers are definitely in that higher risk category for bone loss in the long-term future. So let's take a look at this case. Very severe bruxa. We can see that he's brachyfacial. This case you guys seen a little bit earlier on with some complex dental work and failing teeth. Some because of fractured fractured roots, where the whole bridge is off. There's failing dentition on the side, dental abscesses, whole round of issues. Furthermore, as he's lost some posterior teeth, there is significant parafunction, as well as an erosive component, resulting in the picture that we see, as well as this very severe deep bite. So lots of challenges there to take place. So where did we go? Part of, I guess, answering that earlier question, how do you start to sometimes present these cases to the patient? I mean, that question really is a couple of hours to how to properly do a treatment plan. But, we're trying to do it sort of within a few minutes, so it doesn't do it justice. But something that I find the PROS program really trained me to do quite well is to go through this concept, which is first, you develop a problem list. So everything that, as the dentist, what do you see that is wrong? And often you add in underneath it what the patient wants to achieve as well. So altogether, you have this big list of issues that together that the clinician and the patient sees. Once you have a problem list, you turn this into your treatment objectives, which is what you see on screen. So,
and I think, it is important that your problem list is not just your problem or your list. You need to share this list, if with no one else, is with your patient. And I think a lot of the times, dental students or even my postgrad student, you need to understand the purpose of this problem list is, yes, for you to be able to address these issues and thoughtfully, precisely, but you need to involve your patient and let them take ownership and accountability throughout, but also let them journey that. That's their experience that you cannot get rid of.
Absolutely. And then once you have your treatment objectives with your patient, now these again could be, some of these objectives are dentist objectives. So sometimes we think, oh, we need to increase OVD. The patient doesn't care at all. What are you talking about, right? And then so we have to go through what are the things that we think is important, and marrying up with what they think is important, and collectively, the treatment, the clinician and the patient then ended up with a list of actual objectives that you're going to act upon. Now, in this particular patient, he was quite receptive, as in fact, he actually originally presented saying, just take all my teeth out and give me all in force. That's what he literally said. And I was trying to twist his arm because I still felt that he had a large number of abutments that is still sound to keep. And for such a severe bruxer like that, yes, of course, we can take all his teeth out and give him lots of implants, but the proprioceptive feedback in the absence of any teeth is very difficult to control, and I don't want to smash all these expensive things. So if I can keep some excellent abutment teeth and giving him some segmental implant bridges or prosthesis where he's still got a lot of his own proprioceptive feedback, I feel that I have a better control of his parafunction, generally speaking. So that's why I was, I went through this process with him to say, again, turning a complex case into a simpler form of planning, which is we have roughly two pathways. One is we do what you said, which is we're going to take everything out. We're going to give you some implants or whatnot. The other pathway is this is what I have in mind, and the reason is because. And let me share with you both the pros and cons of both of these options. So the earlier one is a little bit easier to explain. No teeth, knock down and rebuild, start from scratch. Here's an all-4 model. That's not too hard for you to wrap your head around. Now this one is a little bit more complicated, but do hear me out. Right. So first I have to talk about how to increase his bite so that we can flatten his occlusal plane. It certainly took a lot longer time, right? But he, at the end, he can see the benefits of what I was trying to explain, and then he can see that I was coming from a good place. So he actually gave me the trust to do basically as I wished. But we have to start somewhere. So first, got to clear the deck. Got to remove whatever that you definitely cannot save. And as Zoe, as you said earlier on, let's give them a denture, right? Just to see what roughly things look like. Once you have a partial denture in place, now I'm like, right, okay, now I need to increase his vertical somewhat now. So now I'm going back to the drawing board, working out which teeth, sometimes after perio, sometimes after endo, which teeth I can or can't save. The teeth that I can save, right, let's put on some wax blobs there to increase this OVD. Then I can transfer this information back into the mouth to go, right, now I got a little bit more room. I can now modify his denture, add a little bit of composite here and there to see, aesthetically, occlusally, phonetically, am I roughly in the right zone? Once I'm pretty much there, now I can start placing implants in the missing teeth areas, because implant always takes time to osseointegrate. And while we're waiting for that, we started putting some strategic crowns to at the posterior to stabilize his vertical dimension, and anteriorly to give him some guidance. Once the implants have osseointegrated, we're then starting to restore those implants with fixed, whether it's single or multiple units. And they're all, as you can see, they're all splintered prostheses, so that the implants could share the load during function. So that's pretty much it. It's a full mouth type of rehabilitation. Most teeth are either crowned or replaced with implants, with the exception of the mandibular anterior dentition, which we kept in composite, because those teeth are quite small and we don't want to, wherever possible, I try not to crown them. And it does become a maintenance issue in the long term, when we do have to repair or replace some composites, but I feel that's a small price to pay in a large case like this. And of course, I'll be absolutely foolish not to protect that type of rehabilitation if I was not to control his parafunction, which consists of both awake and sleep bruxism. So during the entire treatment, I was using temporary splints, left, right, and center, sometimes for the top, sometimes for the bottom, and I was testing his compliance. I was testing his personalities. Can he work with me here? Because I need him to work really hard. And if I don't have them during that treatment, I'm definitely not going to win at the end. And all this is going to be just smashed to left, right, and center. And I'm really glad that he was able to work me on that. And we still see him every year, and unfortunately he still did not need that 014 yet. So yeah, so that's that. So yeah, so I guess my take-home point for these sort of cases is work with your patient, take your time during that treatment process. You don't need to jump to the end too quickly. Feel free to stabilize them in a holding pattern to make sure that they can manage the underlying cause before you move on to your definitive. Yeah. So let's quickly go through some full arch stuff, Agnes. Yeah, because you're really good at doing dentures. Tell us all about it.
Yeah. So when it comes to moving on with your list of options, when it comes to removable complete dentures, there are mainly those that are supported by soft tissue, okay, and those that can be helped retained, not supported, retained by dental implants, okay. So often we are faced with these situations with patients coming in with dentitions that are quite terminal from their perspective, and they're looking at either a transition or something that is quite immediate. These particular patients, you do have to, of course, talk to them about how their functions or disease matter that has led to the failure of their current dentition. Things to consider as we move to the rehabilitation. And it's interesting with what Ben had spoken about with their way of function. And one thing I think is not emphasized enough often is, and Johnson's mentioned it before as well, the style of even their chewing pattern, how abrupt or how strongly they snap jaw close together. It's something that is not even just your classic clenching or eccentric hold that parafunction we often talk about. But these becomes very important when we are talking about now emerging to a full arch rehabilitation, because those who may know me a little bit, I am a strong believer on neuroplasticity, as well as actually having a patient being able to adapt to the rehabilitation process and how to use their new prosthesis, whether it is retained by their natural teeth with or without implants as they go into edentulous. And one thing that is very important is that the force has to go somewhere. When a person is debilitated by the retention of the prosthesis, they are limited to generate the same kind of power. And often patients relate that to their satisfaction, of course, with the prosthesis. But it is so important that as you provide a bit more fixed option for these patients, where there is implant retained or implant supported, even more fixed, for them to actually understand that in the end of the day, no matter how closely and amazing technology has become to be able to replace dentition, they are replacement teeth. And as an immediate process, as it, like, you know, the faster this happens, there's actually a gap time before they are able to have that same appreciation on that proprioception feedback. And oftentimes they will still chew harder. Okay, we know that actually from literature of even devitalizing a pulp, the tooth often will end up more bite force as a result. And let alone now we don't have the periodontal ligament, so that sense of chew actually now has to come from an increased bite force to actually feel like what it once were with their natural teeth. So let's take this case as an example, because if you ever try to give someone an immediate denture, and this is not the same patient, but I want to highlight this. It is one thing to take models or even use the previous existing denture to duplicate it to become an immediate denture that you provide to the patient, and you reline it at the time of removing all the teeth. You have to ensure that this realignment is done correctly at the right centric, at least. In this particular case, you can actually guess that this particular denture was relined into class 3. So subsequently, this person may as well not have an immediate prosthesis, because it actually just throws all the mandibular control out of whack instantaneously. So what I'm trying to indicate here is, as you stage a patient towards their final rehabilitation, there are these things to consider. It's because the whole point is to allow them a better transition, but it's important to highlight what are the potential things that they still have to be mindful of along the process, given different means. For the earlier case that we show with the periodontal loss of dentition, what we're going to go through here is a removable option that highlights only soft tissue support, which then later on transition into implant. And sometimes, referring back to the question where one audience mentioned, how do we simplify this option? Well, a lot of elderly, sometimes when they come in, and globally, as you talk to them about different options, for example, this man is actually Ben's father or father-in-law.
Yeah, this patient is my father-in-law.
Yeah, and quite commonly in our older generations, depending on the family, and I'm not saying this is the father-in-law, this is just a patient that I would encounter. Their mindset might be that I want something decent, I can afford it, but I don't want to spend too much. I'd rather leave it for their children or their grandchildren. And quite commonly is that they already would be able to indicate to me that I don't want something that's full fixed, sounds too complicated, and I have to get, what if things breaks, it's just hard to maintain. So their mentality is quite clear that they would also want to try just a nice set of teeth. They want things to be quite predictable, so we start with a clearance and just basic dentures without the help of implant. And then it actually, with our visualization and all those things, it fits in quite well with our planning module and staging the transition to enable them to then review whether it meets their satisfaction or from there on to consider implant option. So this particular case, after the removal of teeth, you can actually then appreciate to assess the quality of the tissues. And if we want to be able to attempt a nice fitting and potentially having a suction denture per se, you have to examine the tissue pretty much similar to you would in the maxillary arch. You want to actually check where the tissues are compressible, and of course, along with it, the height and the ridge and the topography, the retromolar pad area, etc., the S-curve, so forth, the height of the frenum, how active is the mentalis, etc., etc. So you would assess those. Oftentimes is you may take a little bit overextended impression at first to be able to define the socket step and work out where you would use your special tray, and you would be able to define on the model and be able to identify here that yes, this model is generated from something that is a bit overextended, and as you move along, you can actually see here this tray is also overextended. So sometimes it's critical for you to examine the laboratory work that comes back, even though you know, presumably you have given your prescription. So here, without surprises, is that you would check this inside the mouth to ensure that where you have mobile tissue that you expect that you want to capture in your secondary impression, for, like, you know, lateral and vertical width. I think I'm going to procedural here. This is about treatment planning. Is you need to be able to visualize is, you know, the end goal, so that you can disclose. These techniques are, don't be afraid to use, because it helps you visualize, especially if, you know, you are generating material for lecture, or you actually wanting to visualize things along the way, you know, to as you consolidate your abilities, etc., so that you are able to actually compress where you want to compress, or, like, you know, allow material to flow where it needs to be. And here you can see we are able to capture the secondary impression. So from here, we are able to then fabricate, you know, a stable base where we're able to assess the patient's OVD, again, something to visualize, not just, oh, hang on, we are measuring 2 points marking on the face, but what you want to actually look at here is that sense of comfort, whether or not this base without jaw movement is stable, is neutral. You want to observe that resting lip posture and have it actually met the criteria of it being static and not doing anything to it yet. You can, of course, able to, why we do things like this is we can mark midline, we can mark where, like, these are your communication tools now to the laboratory, but also some visual reference, you know, with your patient along the way. And you capture the MMR so that you can now have your dental setup in a relationship that you want. Here you may see that, oh, look, the border looks so overextended, etc. Yes, we see that at the moment, but it's part of, you know, using the final capturing of the closed mouth technique of the wash, because you can actually see those areas are recontoured back in the final issue and the formation of the denture. It's not exactly like, you know, there are different ways to capture these in a more time efficient manner nowadays, but this kind of goes step by step, going through what a person can visualize and along the way to identify. Aside from a static try-in, we often will do a functional disclosure to actually see where the active muscles are, so that we can do the lateral aspect trimming as required during function, and especially to, you know, highlight areas that where the tissues are a bit thinner, so they're not as compressible, etc., for adjustment. So the final outcome, if we play the video, is that you can achieve, like, do we have the sound, like, that very stable suction effect to try and maximize the outcome. Now, depending on patients' satisfaction from here, in the end of the day, this is, as I explained, it's a removable prosthesis. It is replacement teeth. And even with the help of the retention of suction denture, sometimes depending on how patient is willing to change their style of chewing rhythm or the way they use their dentition, it still sets somewhat a limitation. But of course, this patient being Ben's family member, we are able to help him move along now to having some implant planning. So once you're able to actually have a nice blueprint of what is most neutral, and this is what I really value in constructing a nice prosthesis first before placing, in this scenario, implant overdenture, is throughout the time frame of a removable denture without the help of implant, I always explain to the patient it's actually a learning journey for them. The denture is well designed of having the maximum tissue support as even an implant retained denture would, because the support still comes from their jaw and still comes from the tissue. The only difference is that to resist the movement of the prosthesis, the retention component of the implant becomes activated. So in this learning journey, the more they are able to practice or learn a new movement of the use of the denture to reduce the amount of lift, and taking that little step of compromise, then they will really enjoy after they're having the implant in place and the retentive component of the implant, but yet they've also been conditioned now to respect the prosthesis design. And what you'll find is that, at least for the patient, and you can let them know, or the frequency of you changing the locator inserts, for example, your expectation of how stable that implant retained denture would be, even talking about fulcrum line, which now of course is established between your inter-implant. However, before you had implant, there's even more fulcrum line that they have already been relearning along the way. So I find that is actually really good. So
do you want me to go through the next part here?
Yeah,
Agnes?
you do.
So once carrying on from what Agnes said, once we have given him a full denture on the bottom, we're now able to carry on with the next part of the plan, which is, well, how can we improve his function? And as we all know, with a full mandible, you could consider an implant overdenture of some sort, or maybe some sort of an implant bridge. So we do need to have some sort of a CBCT. And just before we do that, we made a duplicate denture. So just send it to the lab or using a putty key. Then with these barium sulfate markers, you can now get the patient to wear that intra-orally, and to make sure, again, that's well seated by similar as checking your denture, disclosing for it. I'm now disclosing for my radiographic guide, removing the high spots so that this is actually very even inside his mouth when he's biting down while using a bite registration material. So this is a very rigid, I guess, stable appliance while we're taking a CBCT when he's wearing it. And then the other, once he's done his first set of CBCT while wearing it, and then you scan this guide outside the machine. So it's two separate scans, which then using software, you can marry the two together to get something looking like this. You can then digitally take your radiographic guide on and off. So based on our scan, we're able to extrapolate two various options for him. The first option is something that looks like an all-on-4, using 4 implants within the intraforaminal region. And then option number 2 is to have either 2 or 3 implants more in parallel, able to retain his lower denture. So out of these two options, he eventually chose the lower, the second option, the implant overdenture option, because he has been wearing an upper full denture for a long time, and he's used to the idea of wearing removable dentures. He just wants a prosthesis that's easy to clean, because now given that his son-in-law has been bashing him about the risks of peri-implantitis and how important it is to keep things clean, and he wants this to last a long time. He's okay with the idea of a removable prosthesis. So as part of the treatment planning, we can also digitally assess where we need to carry out osteotomy. He has this very large sort of mentalis that's attached to his bone, so he has a very sharp sort of bony ridge, which we need to reduce. And as part of my plan, I've even placed where my anchor pins in roughly where I'm going to reduce the bone. So in other words, my anchor pin position is also where I'm giving myself a guide to reduce the bone during surgery. Once the guide is made, so you can see that first here the guide is placed, and then the traditional the twisted osteotomy was made. Then the whole guide was taken off so that I can raise the flap and reduce the bone and place the implant, just so that it's a little bit more accurate. You can just sort of pick out where that little spot is there, and there, and that's where the initial the surgical guide pins are, to help me to visualize where the osteotomy is required, and still able to do a guided surgery. So 3 implants in. You've got to be very, very careful with controlling your denture during this healing time. So again, we're using disclosing materials and really removing all the contacts, right around the front, so that when he's wearing his denture, he's not going to be hitting onto the healing abutments or the surrounding neighboring tissues. Even when you reline it with GC Soft Reline, as you can see here, that reline material, as we all know, that over the next couple of days is going to harden up. So we further reduce even the reline material at first. Thankfully, his oral hygiene has been turned around. He's now looking after his teeth a lot better. Locator abutments in, impression, similar to before. So this is a technique where you use the previous radiographic guide, and I put that into his mouth while with the locators in place. So it's a stable prosthesis to take the secondary impression and to take the MMR. So in other words, this, I guess, essentially is my special tray using that radiographic guide. So it's got multiple uses. You can then just take that to the technician to simply change it into the wax and finally finish. So that's that. Regarding removable, occasionally I'll just quickly make a mention with the maxillary implant overdentures. There are some cases that you sometimes need to splint. So for example, in this case here, you can see there's 4 implants for the maxillary arch, but maxillary bone is just so much softer when compared to mandibular bone. Especially in this case, 2 out of the 4 implants needs to be grafted at the same time in soft bone. So I personally just don't feel comfortable at keeping the implants independent. They loaded, so therefore we construct a splinted bar, which then we're really splinting the 4 implants together and having these 3 locator abutments which are screw tapped into the bar for retention. And you can still construct for the patient a palataless, a full denture, but they do have metal reinforcement, as you can see on the inside there, because as the patient's mastication function increases, biting quite hard on that area, it's quite easy sometimes for the acrylic to fracture, which you don't want to in a prosthesis like this. So the main benefit of these removable functions is, prostheses is that it's just patients can take them off, ease of cleaning. You can have as much flange as you like to improve their facial support, and they can be quite a cost-effective treatment option as well. There is we'll move on to the Johnson for the final option, which is a full arch implant bridge. Thank you, Johnson.
Great, thank you, Ben. This patient was referred initially for management of quadrant 1. She suffered a vertical root fracture of 2 abutment teeth supporting a 3-unit bridge. After teeth were extracted, while we waiting for the healing in quadrant 1, she fractured another zirconia bridge in quadrant 2, and there wasn't much furrow remaining. Then we discussed, do we manage quadrant 1 and quadrant 2, or do we manage as a full arch approach? She's quite an anxious patient and quite a severe gagger with a daytime bruxism and sleep bruxism. She feels if we do the segmental approach while we're waiting for implants to heal, or waiting for the implants, she can only function in the front. So, and those teeth doesn't have much furrow remaining from the X-ray anyway. She feels it's only a matter of time before the anterior bridge fails. So she's decided on a full arch approach. Different to the implants overdenture approach, where when we do the fixed prosthesis, we always have to ensure that the patient can clean very, very, very well. So I usually show them photos of how a case of patients failing dentition, but there's a meticulous oral hygiene. I also emphasize often these patients need to spend about 15-20 minutes with different size pixters, superfloss, water jet in the morning and nighttime to clean the prosthesis. But also there's a big emphasis on the dental parafunction, that they need to be wearing the occlusal splint 100% of the time, because any porcelain chipping, that means the prosthesis needs to be removed, sent back to repair, and 1 to 2 weeks later, refitting of the prosthesis. CT scan is taken, and then a significant sinus lift is required in the molar region, and hence this will be done as a delayed approach. And then it's very important to ask the patient of their desired outcome. So basically what they like with the existing prosthesis and what they don't like about the existing prosthesis, whether it's the shape of the teeth or the incisal length. So the patient provided her waiting photo to give us a guide. Her waiting photo was about 10 years ago. Obviously, tonicity of the lip is a little bit different, so I made sure that we can copy the incisal length and the shape of the teeth, but of course it's going to look a little bit different with her lip position. So I mean, it's a good indication, when they provide the photo. Once I have a 80 years old providing a waiting photo that was like when she was 20 years old, and she wants to look exactly like that, and I just say, I'm sorry, I'm just not good enough for you. Yeah. So I mean, sometimes the photo, and by speaking with the patient, you can get their realistic expectations. And then this is with the with a temporary denture, the one to chip because you chopped it, not because of a parafunction. And the surgical guide is made. For the severe bruxer, you want to maximize the implant diameter and also the implant length, and also you want to maximize the AP spread. And then this is after the implant has healed, and then we do a splinted impression taking, and then this is the impression done with a regular body and also a putty. For the incisal plane and also for the bite restriction, we use the surgical guide, and then we use the taller healing abutments to do the bite restriction. We also do an extra-oral photo for the occlusal plane, but what I use is also what's called aesthetic articulator. So it's basically provide a focus plane to for the technician to know the center line and also the incisal plane. A try-in, there's two different ways to try in. Traditionally, there's some acrylic and also a denture teeth set up on two abutments. But some technicians prefer a more modern 3D printed acrylic material and then onto abutment. And this is what we have done in this case. During the diagnostic try-in, this is when the patient said to me, she's known as very teethy. So, and she also wants to have a more square-shaped teeth. So basically, we spent about 10 minutes just putting on composite resin restoration until she's happy with the incisal length, but also the shape of the teeth. And then we go for the design of the zirconia full arch bridge. For a severe bruxer, we usually like to have it as a monolithic material in the posterior region with the external staining and layering, minimal layering without covering the incisal edges. So basically porcelain layering at the buccal aspects only from 3 to 3. And this is the after result, and this is the occlusal view to showing the monolithic zirconia in the posterior region. And of course, you know, we need to provide the patient with the occlusal splint. There's the 3D printed version, which is a bit thinner for patient with a strong gagging reflex, and the traditional version. If you're unsure that the tolerance of the patient, sometimes I make a really thin bilaminar soft material just to making sure they can wear at least something to protect the final prosthesis.
What's the hardest part about treating that patient, Johnson?
Patient is quite an anxious patient, and then she's actually quite a severe gagger, but she's got realistic expectation. She knows that we are there to help her. So for the partial denture, for the full denture, provisional full denture, she also want me to grind the roof out a little bit, and she just used the denture adhesive because she couldn't tolerate it.
Yeah. What material do you usually use for temporary splint?
For temporary splint, I usually use a more soft bilaminar material, so to ensure they can wear something more comfortable. So progressively change into definitive as a more harder nylon or acrylic material. Yeah.
Do you charge a lot for that?
No, not much.
Okay.
Yeah.
All right. Here's a really interesting question, which I'm actually still not sure how to answer. This viewer said that there are clenchers and bruxers, and in this particular case, she thinks that this patient is a clencher, and they gave them an occlusal splint, which made the situation worse. Now I don't know what that situation means. Is it TMD?
Yeah.
Is it dental mobility?
Yeah.
I'm not sure. And they're just saying their question is, would you treat a bruxer or a clencher differently? I didn't realize that there was a much difference in how I would usually treat them.
I think the only thing with the clenchers that I've found in the past that when you offer them the occlusal splint, they tend to clench on it so hard at night, and they wake up in the morning with more myofascial pain. But whether you treat them differently or not, that's
I think it's also if the viewer would like to look back on the past webinar, we have talked of this topic more in depth with a past webinar on splints.
Yeah, it's management of TMD.
That's right. And it depends on the splint material and splint design as well. Yes, there are published articles that with certain personality, actually it's not even clencher or bruxer per se, but with bilaminar splints or actual soft splints can promote the person to clench more or you know have more of these activity, because it is centrally driven in the nocturnal sleep realm. So perhaps consider watching that particular webinar. But for majority of the definitive splint that in a patient where we're just looking at a rehabilitation process where you know TMD is already stabilized or managed, you know there is planning integrated. So I gather here, I'm guessing that situation gets worse with the splint. You're more talking about TMD management,
Not sure.
perhaps, or yeah, not so sure. So, well, that's how we are interpreting your question. So quite different aspects here.
I think it depends on what is actually getting worse. Then we can perhaps give a better answer. And then some very interesting situations. So here's when patient has bilateral missing posterior teeth. Each side had 2 implants on the 3 and the 6 with a view for some sort of a bridging. But the lower jawbone, surprise, surprise, very, very soft. Literally no drilling. So I think it's probably one of those situations that it has a very thin cortex and then a lot of medullary bones. As soon as you penetrate the cortex, the implant literally just drops in. And occasionally we see cases like that. And unfortunately, out of the 4 implants placed, 1 is already failed before loading. The rest of the 3 appears to have reached adequate osseointegration, but there was no RFA done. It was only by reverse torque test at 35. So the question here is that what should we do now? Should we keep on going with fixed bridges, knowing that it's in perhaps not so ideal osseointegrated situation, maybe? Or should we just abort the fixed outcome and use them as like a denture support or retainer and convert for a removable instead? What does the panel think about that?
I think even with a locator abutment in a posterior molar region, normally we do it in where the bone is a bit more dense anteriorly. You predict that a long-standing implant with a locator will be able to withstand the pressure from mastication. If there is a question mark about the density of the bone or the query of osseointegration, perhaps doing the RFA analysis, assessing the integration of the implant, and might probably a more fixed prosthesis with more implants added. It might provide a bit more rigid fixation and support these implants together, provided that they are integrated, as opposed to a removable solitary implants.
And then another very interesting situation is this is getting more creative now, using stress breakers. Using the concept of stress breakers, could you say have 1 implant in the mesial position, so single tooth implant, and then on the distal segment it's a tooth supported bridge but resting on the mesial fixed implant. So let's say your 1.4 is a single implant crown and then your 1.5 is missing. You have tooth number 1.6 and you're doing a 2-unit mesial cantilevered bridge from the 6 with a non-rigid connector on the distal of the implant. I certainly haven't come across too many of those cases before, but in theory, would you guys be comfortable with that?
There has been reports that it can intrude.
Yes.
Teeth.
The teeth can intrude. Yes.
Definitely. So
yes.
I guess there's always that risk that the connector may come off that slot.
Yes.
As the teeth movement, because
yes. Case reports has reported that before. So minor prosthetic complications.
Prosthetic complication will lead to biological complications later on as well.
Yeah. So not ideal, but we literature has given us some outcome on that before.
And I think, I mean, in the scenario proposed, it certainly wouldn't be a default option to look at. And I think it's more when the complication comes, how to manage. So, for example, if you have actually a very robust 6, and you know, sometimes with the correct occlusal scheme, you can cantilever the 5, or you know, vice versa, depending on your implant position, etc. And then so that you can just neatly have 1 unit of work to really look at, rather than linking something so rigid and something that allows movement, and just make the management a bit complicated. Yeah, it's documented, but not my default go-to plan.
Yeah. Any final remarks, Agnes? Any conclusions for the evening before we sign off?
I think, I go back to my comment really to be able to visualize and think of it as an experience of not just for the clinician, but also for the patient. And I am with a constant reminder that when we help to replace missing dentition, no matter the treatment modality, and even with fixed implant replacement, they are a form of teeth replacement that I always will stress with the patient, and carry with it what type of expectation and modification I may recommend, including, as I said, chewing pattern wise. They have to learn the sense of their teeth coming together without that suspension, the finding the rhythm so that they don't bite themselves easily on their tongue or their lips, etc. All the way down to just that sense of chew is only half hard at times, not like as they would hope for. And then it's up to them, of course, like whether how much they take on that on board. But at least it's been made known to them. I think it's very important.
Yeah, absolutely. Johnson?
Yeah, not only is it important to identify the etiological factors, but also continuum management. If the tooth loss is due to perio, so you want to making sure they're cleaning the healing department quite well, but also at the annual review, you want to making sure they're cleaning well. But if the tooth loss is due to dental parafunction, you want to make sure they're always wearing the occlusal splint or temporary occlusal splint, and then wearing the definitive splint. And during the annual review, just always ask the question, how are you going with your splint?
Absolutely. Yeah. Zoe?
With any case that presents, there's always there's multiple ways to manage that case.
Yes.
So I suppose there's no one one solution to fit all situations. So develop like some sort of format that you're comfortable with in your treatment planning. So develop your checklist with every case you come across. That's what we mentioned earlier, with a problem list, desired outcomes, and then formulate some methods to get to the outcome that we desire.
Absolutely. Be methodical. As we all know, that, ladies and gentlemen, that treatment of missing teeth can be quite complex at times. Sometimes not that as complicated, but it can be, particularly for a terminal sort of dentition, and the patient relies on our expertise for comprehensive assessment and management. So as we all are being comprehensive and conscientious during that process of time, try to evaluate your risk for your patients. Just don't forget to evaluate the risk for you, the clinician, as well at the end of the day. So thank you once again. I want to thank the panel here, working hard this evening overtime. We apologize, it's being probably the longest webinar ever, but we thoroughly enjoyed sharing the information, and I hope that you guys find the information helpful as well. So as always, thank you so much for your support of us. Without your support, we would simply cease to exist. If there's anything else that we can do for you, please do not hesitate to email us to the practice and ask whatever questions that you have. And of course, for your CBD webinar, please do enter your details in that link to get your CBD certificate. So thank you so much once again, and look forward to joining you guys next time. Bye now.